Okay, guys. Hey, we're talking about acute coronary syndrome today, and this will be a relatively short lecture. We've talked about a lot of the drugs already, but I kind of want to fit them into the grand scheme of things. And this lecture also starts to touch base on antiplatelet therapy and anticoagulation, which we haven't gotten to yet. I'm going to do that in person next week. I think it's a more complicated topic that warrants a little bit longer and thorough of a discussion and opportunity for you guys to ask questions face to face. So I might skip over some of that, at least the more specific details of it, and then we can talk more in person next week, and hopefully it ties it together for you. So without further ado, acute coronary syndrome is either one of three things. So unstable angina, non-STEMI, or NSTEMI, aka non-ST elevated myocardial infarction, or STEMIs, which are ST elevated myocardial infarctions. A lot of ER visits nationally are frequently associated with chest pain. So chest pain is easily one of the most common presentations for people coming into an emergency department or urgent care. Not always acute coronary syndrome, but it fast tracks you because if it is, it's something that needs to be addressed very quickly or it can be fatal. So if you come in, even if it's long-standing heartburn, that's something we can rule out, but oftentimes if you get somebody coming into the ER with chest pain, they're going to be seen very quickly. Uh, Several people a year die due to myocardial infarction, so it is a pretty serious medical concern. It's obviously an emergency, as we just discussed, and it needs to be addressed very quickly. This shows just the differences between the three types, and I'm sure you're talking about this in other classes, but just for review, I think it's really easy to remember the differences. Obviously, the name is a big clue, so ST elevated, right? So you have to see some EKG changes with that classic ST elevation. If there isn't ST elevation, or if it's ST depression or T wave inversion, then you look at troponin levels. So if their troponin is elevated, and troponin usually should be non-existent, basically, maybe very, very small amounts in the body, but basically undetectable by lab. If there is some detectable, it's likely a sign of cardiac tissue, of some sort of infarction and cardiac tissue death. And that's where we have the question of whether it goes to NSTEMI or unstable angina. So let's say your EKG looks normal, or ST depression or T inversion. Your troponin's elevated, well, that's probably an NSTEMI going on. It's not elevated, that's unstable angina. And so in order of severity, STEMI being the most severe, then NSTEMI, then unstable angina. The arterial wall builds up with plaque. So we just talked about cholesterol. So the idea is that over time, LDL transport proteins are bringing cholesterol and depositing them places where they shouldn't be. So generally speaking, somebody who doesn't have high cholesterol or cholesterol issues shouldn't have a lot of cholesterol buildup in their arterial wall. Every once in a while, you get these plaque buildups that get big. This is a little bit exaggerated, I think. I think they'd probably be a lot longer. I don't think you'd really see just a huge deposit in one small spot, but it's possible. But anyway, this is just a drawing, of course. So obviously not a real picture. So you've got blood flow that's getting impeded, and that's what we're looking at as far as the differences in presentation. So the difference between the middle one and the bottom one would be a fully occluded vessel for the most part. There's really no blood getting through. So a complete infarction is often what you'll see causing the ST elevated myocardial infarction. And then what you'll have with a partial blockage or almost complete blockage is where you get unstable angina or NSTEMI, some of those lower category acute coronary syndrome presentations. All right, let's talk about unstable angina for a second. So angina pectoris, similar to typical angina. Some people just get chest pain variously, and we'll talk about nitrates at the end of this lecture really quickly. The class of drug we haven't really discussed from an oral perspective yet. And people with angina will get unstable angina that's a lot more severe than the typical chest pain that might be associated with some other cardiac conditions. Less exertion is required to get to that chest pain, and may worsen suddenly or come and go quickly. So if you have somebody who gets an occasional episode of chest pain and they have to pop a nitroglycerin occasionally, this is going to be a more severe or more an episode that's easier for them to get to than previous chest pain episodes. We talked about all the rest of this stuff already. There's really no myocardial injury here. It's just a partial occlusion of the artery. Non-ST elevated MI. So NSTEMI, similar to UA. You've got probably some myocardial injury going on, so either a fully occluded smaller vessel or partially or almost completely occluded larger vessel. Same EKG changes on the UA, as UA, so that's going to look, and again, we're looking at the positive biomarkers here. So symptoms are going to be typical of what you might expect a heart attack to be. And then STEMI, of course, has the classic ST elevation with myocardial necrosis. Our goals of therapy, UA and STEMI, we want to prevent total occlusion of the infarct related to artery. So we want to see if we can get some sort of intervention. But this isn't usually a huge emergency. I mean, yes, you're probably going to get the person in for imaging. You're going to see if you need to put a stent in. You're probably going to try and do that within the next 12 hours, 24 hours, depending on your cath lab access. But otherwise, you don't need to really do a whole lot in the meantime. We'll talk about the things you do, but it's not a ton of medical management. STEMIs, you really need to act very quickly. And in fact, there's a lot of national benchmarks around time. So they call it door to needle time or door to balloon time, which is where you get your, how fast can you get your patient from entry to the emergency department into the cath lab. And the faster, usually the better outcomes. So initial therapy for any acute coronary syndrome. So this is, think about somebody in the ambulance on their way to the hospital, somebody in the emergency department waiting for a cath lab room to open up, or cath lab staff to get ready for the patient. MONA is an acronym, but it's not really exactly in that order, but you can remember that if you want. Morphine, oxygen, nitroglycerin, and aspirin. In real life, what I see done is morphine's not used a ton, but these three are, especially nitroglycerin and aspirin. So usually by the time they get to me in the emergency department, they've gotten aspirin. So a lot of times patients are on an aspirin regimen at home, or they have aspirin at home. So they call 911. They're talking about heart or chest pain type symptoms. And so they say, well, take 325 milligrams of aspirin, chew it, swallow it. It's relatively benign. If the person's not having a heart attack, it's not really going to have an adverse effect. Yes, it might inhibit their platelets' ability to clot together for a little bit, but it's ultimately not really going to have an impact on somebody who's otherwise relatively healthy. So there's really no risk in doing that, which is almost always why you see people get to the hospital who've already taken aspirin. So that's usually something we don't do. It's something done in the field or at home. Nitroglycerin is the common treatment for chest pain. And it's the same thing we talked about with respect to it being a vasodilator in acute heart failure. However, in this case, people are often taking it sublingually, either as a spray or a tablet. And if that doesn't relieve it, you can always start a nitro drip on somebody. So again, the same medication, exact same process for acute diastolic heart failure, but it also works to relieve preload and afterload. It dilates those coronary arteries, opens them up a bit more. So whatever vessel is occluded, maybe you can just push a little bit more blood through there because you're opening it up. The idea is you can relieve some of those symptoms that are going on. And then oxygen, certainly if you know the person's getting hypoxemic, which is common in a myocardial infarction, that's something you can do. It's an easy intervention. And morphine is really the second line pain option. So if somebody's not responding to nitroglycerin first, then you're going to give morphine. I don't see opioids used a ton in this case. Certainly it's an option. Every once in a while we get a ton of level 1s through Abbott, and I'd say maybe like 1 out of 20 might need a little bit extra pain control. Usually they're just whisked away so quickly there's really not time. It's like we get all their other medications on board, and then we get them up to the cath lab. This is missing one major class of medications called the P2Y12 inhibitors, and we'll talk about those in a little bit. That's another antiplatelet agent class. Okay, so your reperfusion strategy from a pharmacologic standpoint is going to be getting the patient ready for percutaneous coronary intervention. So that's getting a stent placed, going to the cath lab. That's going to be your primary goal. And for us, or if you aren't working in interventional cardiology, like somebody like me, you care about the beginning of it. And that's really medication driven and patient stabilization. So we're looking at antiplatelet therapy. The person needs aspirin, and they need sorry, this is a typo. It's a P2Y12 inhibitor, not PG. Glycoprotein 2B3A, sorry, another typo. Wow, I'm really bad here. 3A inhibitor. Those are the different antiplatelet options you have. And again, I'm going to kind of gloss over this now and talk about these a little bit more in detail, but we'll cover them both places just for the sake of getting as much information into you guys as possible, because these are really commonly used medications, so it's important to talk about them a few times. And then your second arm of that is antithrombotic therapy, which are more traditional anticoagulants that work on the clotting cascade, like heparin or other variants. Most patients are going to be on heparin, so that's really all I care about for this one. We'll talk about bivalirudin a little bit too. And then again, cath lab. If you can't get somebody to the cath lab, you can use a thrombolytic agent, which is a clot-busting drug. They mostly use that for stroke patients, but it depends on your access. So if you're in a really rural location with limited access to a facility that has a cath lab, then that might be the best option. It depends on how long a helicopter ride would take to get you to a place with a cath lab. There are a lot of strategically placed, even kind of freestanding catheterization centers in rural areas, especially in this state. I'm not sure how other states do it, but I imagine if you're in the middle of nowhere in, I don't know, I'm trying to think of an area that's really remote, like Wyoming or Montana or something like that, where you have to get airlifted to this tiny ER in the middle of nowhere. That might be a case where all they're going to have is a thrombolytic therapy. And the outcomes are not as good with thrombolytics. They do help, they're effective to a certain degree, but stents are going to be the way to go in the long term. So stent actually goes in and pushes the artery open. You get a continuous blood flow through there, and if you compare that to the idea of a clot-busting drug, so for example, if you gave somebody a thrombolytic agent, that drug comes in, breaks up this clot kind of moves down, you've still got this occluded artery to deal with. So a thrombolytic is really just a band-aid to get somebody, that person's still going to need a stent eventually. And thrombolytics do increase bleeding risk and things like that. So there are some concerns with that. Stenting is just the way to go if you can get the person to the cath lab. Let's talk about risk and then kind of work our way up. So starting with unstable angina and NSTEMI, risk stratification is really necessary for determining whether you want to do an invasive or conservative treatment strategy. And I'm not going to test you on this stuff, so you can tune out a little bit if you want, but just to give us a background, because it does direct where our therapy goes depending on what we're going to be treating. So the TIMI risk score is something that looks at a couple of different factors and assigns a point value. And depending on where your point value goes, it's your percentage of mortality, and I can't remember what the time frame on that percentage is. Risk of mortality, new or recurrent MI, or severe recurrent ischemia through the next 14 days. And depending on where your TIMI risk score lands, that's how we're going to treat. So obviously the higher risk score, the higher mortality, you're going to be a more aggressive treated patient. So the early invasive strategy is for very high risk patients. So those patients on the higher end of the TIMI risk score, they're going to get PCI less than 12 hours from hospitalization. So again, this still isn't as urgent as a STEMI. A STEMI, you're probably doing it within an hour. So this is 12 hours. Usually these patients, you start them on a heparin drip, get their heparin levels to the point where they're therapeutic, and that gives them a good anticoagulation on board. They also have time to give them aspirin and other medications, time to schedule the cath lab so you can figure out where you can slot the person in within the next 12 hours. Really not a big deal for the most part. And they're just going to be monitored on telemetry until they can get into the cath lab. Invasive, which is delayed PCI, which is over 12 hours after hospitalization. This is a person who needs to be hospitalized and needs to be watched, but you're gonna wait a little bit. So again, you have really plenty of time to get all your drugs aboard. Conservative means you aren't going to go to the cath lab. This is a really low risk patient, probably more like the unstable angina type patients. I don't think for NSTEMIs they ever treat them like this, and certainly imaging is going to direct how aggressive you're going to be in some of these cases. How occluded is that vessel? How much benefit would the patient get from an invasive intervention immediately? Thrombolytics don't have any role for UA or NSTEMI. The only real time we give thrombolytics, again, is for STEMI patients who can't get to a cath lab in time. All right, so here's some other things: invasive strategy, and then again, I'm not going to test you on that stuff. It's just FYI. STEMI, easier, I think. You don't need to risk stratify it, at least from a diagnostic and interventional point of view. You really just want to get them to the cath lab in 90 minutes. Our center's time frame goal was 60 minutes. It might be more aggressive than that now. So the national standard is 90, but there are really good centers will try and get better than that. So we try and get everyone to the cath lab within 60 minutes. And you might think that's pretty easy, especially if you have a big center. So we have like 5 or 6 rooms in our cath lab that are ready to go, not at any given time, but we always have an interventional team on call, so we could churn through a lot of level 1s in a night if we really had to. Basically, we would never be in a situation where we can't take a level 1. It's just pretty infeasible. And then you think about all the other hospitals in the cities that can handle level 1s. Pretty much every major hospital has a cath lab, so there's tons of options for patients. If one happened to be full, you say, nope, we've got 2 interventional teams on call, they're both working cases right now, send them somewhere else. You can probably find someplace in the metro area with a cath lab that can get you in within that 90-minute window. Now, where this gets a little tricky is when you get that patient coming in with kind of non-specific symptoms of chest pain, maybe GI-related symptoms. They're kind of sitting, maybe they don't get an EKG right away, and by the time, or maybe they've been in the ED for a while due to something like they're nauseous or they feel just generally ill, and you're trying to work them up for whatever it might be, and then all of a sudden you start to see on the monitor that things are changing, and they actually go into a STEMI in the ED while they're sitting there. I've seen that happen a number of times too. People get sick for a reason, and sometimes that reason is that they're almost having a heart attack, right? And so it's not totally out of the question to see something like that happen. And that's where you get some dings on your numbers, because, oh, that person was sitting in your ER for 2 hours before they got to the cath lab. Yeah, but there's other things going on. Thrombolysis, if you can't get to that cath lab within 120 minutes, so 2 hours, then you're going to be a thrombolytic candidate. And ideally, you can give thrombolytics really quickly. So if you're a small ER, you should know right off the bat. Sorry, I got a timer going off. Just a second. Sorry for an interruption. Anyway, as I was saying, if you're a center, you know what you can do as far as how fast you can get somebody to a catheterization facility. And if you can't do that within 2 hours, you can start thrombolytics immediately while you set up transportation or get them airlifted somewhere else. And all places should have this drug available. You can mix it up quickly and administer it right away. It's really not a complicated process. So within 30 minutes is not a hard ask for these people. Is what I'm trying to get. Rescue PCI, failed thrombolysis. These patients who get thrombolytic agents are going to go somewhere and get worked up. They aren't just going to go home after that. That's probably obvious, but that's something to consider. Some patients might go into cardiogenic shock, heart failure, like a severe decompensated heart failure picture, or just be generally unstable, which puts them at risk for arrhythmias and things like that, like ventricular fibrillation. And those are patients we want to watch really carefully and consider ultimately interventional options if we can. Okay, again, I'm going to go over this kind of quickly, and then hopefully after we talk about the agents a little more in depth, you can kind of come back and reference this. But basically, I want to just point out that antiplatelet and anticoagulation for UA and STEMI is slightly different, but very similar. So really, for antiplatelet agents, we're going to do the same thing regardless. So you're going to give aspirin to all your patients, and then you're going to give one of these agents. So clopidogrel, prasugrel, and ticagrelor are all P2Y12 receptor inhibitors, and those are going to be basically interchangeable. Again, we'll talk about I've got a slide kind of comparing some of the differences. In our facility, we use ticagrelor. It's got a faster onset, and it's slightly more potent than the other agents, but all of them are approved for this. If you can wait a little bit, clopidogrel is probably the best drug because it's cheap. You can give this, and it takes a longer time for it to do its antiplatelet effects than compared to ticagrelor, but it is inexpensive. Generally speaking, for these patients, UFH is unfractionated heparin, and that's the drug we're going to give. It's cheap. It's easy to titrate. You can turn it off if the patient starts to bleed. It's a very straightforward medication. The other ones, enoxaparin and fondaparinux, are long-acting subcutaneous injections that are a little bit more expensive. And bivalirudin is a little bit trickier to manage than traditional heparin, but it is a continuous infusion. So usually unfractionated heparin is our drug of choice in these patients. For a STEMI, you're looking at unfractionated heparin only or bival. So the big difference between STEMI is that you get them on either unfractionated heparin or bivalirudin immediately, whereas these subcutaneous shots can take a few hours to start working, and we don't have a few hours. We want to get them anticoagulated quickly. And so that's where these drugs come into play. So that's really the big difference I want you to remember from this. From an antiplatelet stage, exact same thing. Don't worry about these as much. I don't really care, about the alternate stuff. But and then for the anticoagulants, just know that unfractionated heparin can be used in both patients. That's probably what you're going to see. But in a UA and STEMI picture, you could use the enoxaparin or fondaparinux if you wanted to. I just think it's going to be more uncommon to see that. Okay, so these are different P2Y12 inhibitors. You've got a couple different medications here. And again, we like ticagrelor. It's reversible. It's got stronger inhibition properties. It's got a really rapid onset compared to clopidogrel. Clopidogrel is Plavix. It's been around the longest, but it's slow. And ticagrelor has an advantage. Prasugrel has might look kind of similar to ticagrelor. However, there's a lot more bleeding risk associated with prasugrel. It's got some contraindications that make it not as usable. Also, prodrug. Ticagrelor is not a prodrug. It doesn't require any hepatic activation, which is another advantage. You don't have to worry about genetic polymorphisms interfering with your ability to get the patient to therapeutic platelet inhibition level. I put this up here just to show the difference in doses. I'm not going to test you on the dosing, so this is really just for your information if you want to read more about this or look into this. Basically, it depends on what type of center you work at or where in the world you work. But usually for aspirin, for a STEMI, we're going to be doing 325 milligrams for everyone. And here gives the different doses. So really the big difference between, like if I took a daily aspirin for prophylaxis or a daily Plavix for prophylaxis, I'm taking a really large dose. So these are loading doses that you're giving people. And so that's really the only thing. Again, I'm not going to test you on those doses there. Glycoprotein 2B3As, I'm not going to test you on this either. They're really potent agents. They're used intravenously, and they'd be used during PCI. So this might be well, okay, let me step back. These drugs were popular in a time when P2Y12 agents weren't well understood or even used in this area. Now, since we have P2Y12 agents that work orally very quickly, people coming in with a STEMI are sitting and talking to you almost always. So you can have them swallow a medication without issue. And then what you're going to get is a good platelet inhibition with that one process. Now, glycoprotein 2B3A could be used if you couldn't get somebody a P2Y12. But really, they've kind of fallen out of favor. We don't use them quite as much anymore, and I won't test you on them. I just don't think they're relevant. Unless you work in interventional cardiology, you're probably never going to see these medications used. They're also really expensive. So what's the point of all this stuff? Well, really, we're trying to prevent the clot from growing. And again, we're going to talk about this in a lot more detail next week. But we want to prevent that clot from growing, prevent new clots from forming. These drugs, anticoagulation and antithrombotics, do not break down clots. And anticoagulation, antithrombotic therapy, one thing to think about, you do have to be able to give it IV. So the only drugs we have are heparin, low molecular weight, fondaparinux, bivalve. They're either IV or subcutaneously. There are some interesting trials looking at some oral medications that are anticoagulants. We'll talk about those next week as well, but there's nothing approved as of yet. Thrombolytics. So thrombolytics in conjunction would be, remember, these are drugs that we'd give to somebody who can't get to a cath lab within 2 hours. So here we have a couple different agents. We almost always use alteplase. I don't really know if we even carry the other two. But here's some contraindications. I'm not going to test you on the contraindications of this stuff. We'll talk about thrombolytics in a lot of detail during stroke. That's where they come into play. But for now, we'll leave it alone. Just know that they're used in a case where you couldn't get to a cath lab, and be able to recognize that alteplase is a thrombolytic, and you should be okay for the exam. Okay, let's talk about some other stuff. So once somebody's through the cath lab, hospital therapy, what about ACE inhibitors? So ACE inhibitors, we talked about this during hypertension. They are a preferred agent post-MI. Usually start within 24 hours of myocardial infarction, or especially if they have heart failure or left ventricular dysfunction. We don't give IV. There is an IV ACE inhibitor called enalaprilat. We don't do that. It's just we don't need to be that aggressive. You can start an oral therapy. Consider in all patients post ACS, got good evidence that says people have mortality benefits on ACEs post MI. If the ACE is contraindicated or not tolerated, we can use an ARB. Again, if that's contraindicated, you could try the renin inhibitor. Hypotension, pregnancy, bilateral renal arterial stenosis would be another contraindication. Statins. So you start it if a person's not currently taking, and I said this in the last lecture, but I'll just say it again. High dose, high potency. So you're looking at 2 statins only. So rosuvastatin or atorvastatin. Those are the only 2 you're going to use, and you're usually going to start not at the highest dose, but probably that second highest dose. So that like rosuvastatin, you're probably going to be at 20 milligrams a day, and atorvastatin 40, which is a pretty whopping dose to start a statin on. Other early hospital therapy, calcium channel blockers. You can recommend if they're having ongoing ischemia or angina, especially verapamil and diltiazem can help with some of those, relieve some of those symptoms for like an unstable angina patient. And if you have a contraindication to a beta blocker, that would be something to consider too. We'll talk about beta blockers on the next slide here. And aldosterone antagonists would really just be used in the setting of heart failure. So go back to your heart failure treatment, and you're going to apply it into those patient populations. Long-term management, beta blockers are going to be indicated as well. So beta blockers and ACEs are core management for these patients, and they're going to be indicated for all patients, status post acute coronary syndrome, less contraindicated. If they aren't already started, you're going to initiate within 2 to 3 days of the event, continue indefinitely, and then titrate up if you get heart failure type symptoms. We already talked about ACEs and statins. So these really are the 3 things. Beta blockers are a little bit tricky during the acute event. So you usually don't start the beta blocker until a little bit afterwards because it can hinder the heart's ability to recover if you're not allowing it to beat and beat as hard or as fast as it would normally. So you might want to be careful with that. We do sometimes give people beta blockers in the short term. So if somebody comes in having a STEMI and they're really tachycardic, we might give them like some IV metoprolol or an oral dose of metoprolol, small dose to help bring that heart rate down a little bit. That's rare. Again, I've been in hundreds of these things where I've done the medication management, and I've probably used metoprolol once or twice. It's really odd to do that, but usually you're talking about beta blockers after, but they are really an important part. So people long-term post-ACS are going to be on beta blockers, ACEs, and statins, and that's going to be... So I should update this. Target LDL aggressively, question mark. Not really, just use a high dose, high potency, and remember, we don't really target levels anymore. So you might find some people are a little old school and they do want to go with a level targeting, and that's not necessarily incorrect, but it's not recommended per the current guidelines. Other goals, A1C, hemoglobin A1C, that's a diabetic biomarker for long-term glycemic levels. Want to keep that less than 7%. Stop smoking, lose some weight if you need to, exercise 3 to 4 times a week as tolerated. Okay, switching gears a little bit to stable ischemic heart disease. This is preventing angina and preventing ischemia. So the major drugs we're going to do this. So this is somebody with occasional angina episodes that isn't going into full UA or a STEMI or anything like that. Nitrates. So nitrates are a cornerstone therapy for acute coronary syndrome and stable angina. So nitroglycerin tablets are sublingual tablets. They come as a spray, patch, and an ointment too, but really the tablets are the ones you're going to see people use commonly. Some of the physicians and PAs I work with like to use the patches and the ointment on people in the emergency department, like if they're having some chronic angina. It's a little bit harder to control the dose that way, but if they're responding well to sublingual nitroglycerin, it might be a good option to try something longer acting. Like the patch is a daily patch. The ointment absorbs transdermally and works quite well as well. Is another option for people. I don't see the spray used all that much. It's rare and it's expensive. We don't even carry it at our hospital. So what you'd give somebody if they had chest pain, the way you use this medication is you do 1 tablet every 5 minutes for 3 doses. If you aren't getting relief on that second dose, it's okay to take the 3rd dose, but call 911, because if you aren't relieving the chest pain by opening up those vessels, you might have a pretty serious problem going on. A lot of people will say, yeah, I get occasional chest pain upon exertion. I'll take 1 and I'm fine. And it's just my normal thing. It happens once a week. That's pretty normal for some of these patients. Now, after somebody's had a heart attack, it's always important to give them a prescription for this so that they can have that available to them, because it can help them relieve symptoms and possibly keep those arteries dilated in the acute phase before they can get into treatment if they do happen to infarct again. The tablets degrade over time, if exposure to heat and air. So every time, if you open that jar, you get 6 months, that's it. Get a new one after that, regardless of if you used any. Exposure to air, they actually get a weird taste to them. I think what I've heard, it's like a metallic taste, a bitter taste. And that means that they've actually, they aren't as effective. Or maybe I have that backwards. Sorry, I've never actually tasted one. And I've never heard this from a reputable source. It's kind of a rumor out there, so maybe I shouldn't even say this. But apparently the taste changes over time as they degrade. So I think it actually get less potent, but I'm not entirely sure on that. Long-acting nitrates. So we can use so if you have somebody who's popping sublingual nitrogen a couple times a day, but they really don't have any other issues, you can give them long-acting nitrates. So there's a product called isosorbide. It comes in two ways, mononitrate or IMDUR or dinitrate. The mononitrate's the common one. It's an extended release once daily. You do get some side effects of flushing and headache, as you might expect, but you don't get huge effects on blood pressure, which is nice. It might lower it slightly, but not substantially. And the IMDUR formulation is once daily. There's dinitrate, which is an older TID, BID dosing, and you get more hypotensive effects, more flushing, headaches. So if you're prescribing this, make sure you're prescribing mononitrate. Don't prescribe the dinitrate. Your patients are probably going to be more happy with you. If they're on mononitrate, they've maxed their dose and things aren't working, you could maybe go to dinitrate. You might get some more potent effects if you're dosing it spread out like this, but that's a little debatable. There's a newer therapy called ranolazine or Ranexa, which has no effects on blood pressure or heart rate. Its mechanism is sodium, potassium, and calcium ion effects in the cardiac myocyte. It may prevent calcium overload, potentially, so the heart's not working as hard, and it relieves angina that way. It is brand name only. It is kind of expensive, and it's a second line. Most people do well on isosorbide, so you don't really need to give this medication to the general public. But I do see it prescribed occasionally. It is a second line option. Okay, that's it for ACS. We'll talk about antiarrhythmics next, and next week we'll come back to antithrombotics and antiplatelets in more detail.